Today I'm going to talk about diabetic foot assessment and risk stratification. The learning objective of my lecture, I'm going to cover epidemiology of diabetic foot disorder and pathophysiology and risk factors of diabetic foot ulcer, comprehensive foot assessment and physical examination of the foot, risk categorization, and take-home message. Diabetic foot disorder are a major source of morbidity and a leading cause of hospitalization. One of the most common complications of diabetes in the lower extremity is the diabetic foot ulcer. And as you can see, the number of those patients who have diabetes in Kingdom of Saudi Arabia are about 24%, and 15% of them going to have a foot ulcer. Foot ulceration is the cause of approximately 85% of lower extremity amputation in diabetes patients. Several survival rates after amputation are generally lower for diabetic versus non-diabetic patient, and 50% incidence of a serious contralateral foot lesion following an lower extremity amputation, and 50% incidence of contralateral amputation within 2 to 5 years of lower extremity amputation. It has been estimated that every 20 seconds in a world, a lower limb or a part of a limb is amputated due to complication of diabetes. Mortality following amputation increases with the level of amputation and ranges from 50 to 68% at 5 years, which is comparable or worse than for most malignancies. It has been reported that up to 85% of amputation can be avoided when an effective pediatric foot care is adopted. As you can see in the graph, the 5-year mortality rate, when we compare it with diabetes-related wound and amputation, worse than all type of cancer except lung cancer. Why are diabetic prone to foot ulceration? Because there are many risk factors, a systemic contribution like controlling a blood glucose level, duration of diabetes, peripheral vascular disease, blindness or visual loss, chronic renal disease, older age, and local issues in the foot, peripheral neuropathy, foot deformity, trauma, footwear, callus formation, history of perior ulcer amputation, prolonged elevated pressure, and limited joint mobility. So from there, we have to do diabetic foot assessment, and we have to do general inspection, and also we have to do neurological assessment and vascular assessment for every patient that have diabetes. The inspection, we have to do dermatological, look for skin status and color thickness and dryness and cracking of the skin. Infection, check between toes for fungal infection, and also we have to look for ulceration on the feet. And also we have to look for the callus formation, blister, hemorrhage into a callus, hair growth, and interdigital lesion, tinea pedis, and nail appearance. And also we have to look for muscle skeleton, for muscle wasting and biomechanics of the foot. And also we have to look for deformity, a deformity such as hallux abductori valgus, lateral deviation from normal shape of the first metatarsophalangeal joint, and also claw toes. And we have to also to look for hammer toes, metatarsal head prominence, which lead to increase the pressure underneath of the metatarsal, and of course shark joint, because it has a rocker bottom deformity in the plantar aspect of the foot. The neurological assessment, we have to use a 10-gram monofilament test plus at least one of the following assessment: vibration, pinprick, temperature sensation, ankle reflex, and vibration perception threshold. If we have more than one abnormal test would suggest loss of protective sensation, while at least 2 normal tests would roll out the loss of protective sensation. And as you can see in the screen, in the left side, the number 1, we use a 10-gram monofilament. You can see we apply the monofilament in the hallux and first metatarsal head and fifth metatarsal head. Also, we are using 128 Hertz tuning fork to apply it in the dorsal hallux. And also we could use IB switch touch, which look for the light touch sensation. And also we have to perform a vascular assessment in person with diabetes and a foot ulcer. We have to palpate foot pulse. We have to palpate posterior tibial artery and the dorsal pedis artery. And if it's absent or we cannot palpate, we could use a Doppler to hear the waves, if it's mono or bi or triphasic waves. And if we could not find it, we can go for ankle brachial index or to systolic pressure. And if we couldn't find or we have a weak pulse, we could refer a patient for vascular consultation. So from the neurovascular assessment, the International Working Group of Diabetic Foot, they categorize the risk stratification system and corresponding foot screening frequency. And they categorize it from 0 to 3, where the 0 is very low and 3 very high risk for foot ulcer. The category 0, very low ulcer risk, and the patient will have good sensation and good blood flow in the extremity. So we examine this patient every year. Category 1, low ulcer risk, so patient will have loss of protective sensation or peripheral arterial disease. And moderate risk, loss of protective sensation and peripheral arterial disease, or loss of protective foot deformity or peripheral arterial disease and foot deformity. And we are going to examine this patient every 3 to 6 months. The high risk, loss of protective sensation and peripheral arterial disease, and one of the following: history of foot ulcer, lower extremity amputation, and end-stage renal disease. So we have to examine this patient every 1 to 3 months. This is the form that we should have it in every clinic. And also we have to remember the stairway to amputation: diabetes, neuropathy, ulceration, vascular disease, infection. Those elements lead and cause amputation. So we have to stop this stair by education program and the screening program. Take home message: not all diabetic foot complications can be prevented, but it is possible to reduce their incidence through appropriate management and prevention program. Pediatric foot and ankle physician and the specialist should play an integral role in providing ongoing education and management of new or impending lesion. The multidisciplinary team approach to diabetic foot disorder has been demonstrated as optimal method to decrease amputation rate of lower limb in high-risk diabetic patient. Finally, a screening program for diabetic foot in Kingdom of Saudi Arabia is a must. And thank you.
Thank you, Mr. Saad. Thank you.